Okay, when we talk about Tylenol poisoning, remember there's 4 stages to Tylenol poisoning, and we'll start with stage 1. The first stage of Tylenol poisoning is the first 24 hours. So it basically starts with the patient ingesting the excess amount of Tylenol and lasts from that point until 24 hours later. And in that first 24 hours, the classic presentation is the patient has flu-like symptoms. So the patient will be nauseated, they'll be vomiting, they may be weak, they may have generalized pain or myalgias, but their symptoms are limited to that. They're limited to the flu-like symptoms. Now, around 24 hours, we'll enter stage 2, and stage 2 typically lasts from about 24 hours to about 48 hours from the time of ingestion. And in stage 2, the big thing we see is this is where we start to see the liver fail. We all know that Tylenol is a hepatic toxic drug, and this is exactly what we see in stage 2. The patient will start to complain of right upper quadrant pain. We'll see that the patient's liver enzymes will go up, and we'll see that the patient's clotting factors will start to become messed up, starting with an increase in the prothrombin time. The other thing that we can say as a generalization in critical care is that typically in critical care, whenever you have liver failure, renal failure will be like the next thing to occur. And it's not uncommon for patients with Tylenol poisoning in that second stage to actually start to develop renal failure as well. So again, second stage, we see an increase in the liver enzymes, we see right upper quadrant pain, and we may or may not see renal failure. Now, the third stage kicks in around 72 hours, and it lasts typically from about 72 to 96 hours. And the big thing we see in stage 3 is this is where we see the peak of our liver dysfunction. This is where we're going to see the patient have an increase in all of their liver enzymes. We'll see that they start to turn yellow and get jaundiced. We may see the patient gets DIC. And the other thing that we'll see with these patients is their level of consciousness starts to change as they get hepatic encephalopathy. Now, if the patient has not had a decrease in their level of consciousness, we actually see that nausea, vomiting, and malaise often come back. So the first 24 hours, they've got flu-like symptoms. Second 24 hours, the flu-like symptoms go away, but the patient's got starts to have right upper quadrant pain and their liver starts to fail. And then the third 24 hours, we see that the liver is continuing to fail and all those flu-like symptoms come back. They return. Now, one of two things is going to happen at the end of stage 3. At the end of stage 3, if this is going to be a fatal overdose, the patient will die. The patient doesn't go into a stage 4. They just die at the end of stage 3. However, if the patient is going to survive this toxicity, then the last stage they'll go into is they'll go into stage 4, which is basically remission. The stage 4 process can take anywhere from a couple of days to a couple of weeks. This is where we see the liver enzymes come back to normal. This is where we see the patient become asymptomatic, and eventually the patient does fine and goes home. But again, if the patient is going to die from this toxicity, they'll never see stage 4. They'll just die at the end of stage 3. Okay, when we talk about the priorities for treatment of Tylenol poisoning, remember that it typically takes about 150 milligrams per kilo of Tylenol to be toxic. The other thing is, remember that we want to measure the Tylenol level at a predetermined point. The usual point we use is 4 hours after ingestion. And based on what the Tylenol level is at 4 hours, we're going to use a normogram to determine how we're going to treat that patient. So it's real important, if at all possible, that we get that Tylenol level right at 4 hours or as close to 4 hours as possible. It is appropriate to give these patients charcoal. If they're early on in their toxicity, if they're within the first couple hours, charcoal's not going to hurt, and it will bind up some of the Tylenol, but not a lot. The actual treatment for these patients is the drug Mucomyst. And when we give Mucomyst, remember that we give it orally and we give repeated doses over and over again. We'll typically give the patient 140 milligrams per kilo as their initial dose, and then what we'll do is we'll give them 70 milligrams per kilo every 4 hours for the next 17 doses. So it takes multiple days to give them Mucomyst. If you've never given Mucomyst before, the big thing you need to know is it really, really stinks. A lot of times it's very difficult to give, especially kids, because you're not going to like giving it because of the smell. They're not going to like taking it because of the smell and because it tastes awful. So sometimes it's a challenge to get the Mucomyst down, and sometimes we need to actually put an NG tube in. Now, luckily for us, a lot of facilities now have acetadote. Acetadote is actually the IV version of Mucomyst, if you will. It's not exactly Mucomyst, but it's an IV version of a Tylenol antidote. It's a lot easier to give. There's a lot more patient tolerance, and it tends to work much better. So a lot of places are using acetadote now. Okay, when we talk about ethylene glycol and methanol poisoning, remember that there's a couple of classic things we see with any type of alcohol poisoning. The first thing is people with alcohol poisoning, depending on how much poisoning they have, are going to act like they're drunk. So if somebody has a little bit of ethylene glycol or methanol poisoning, they may act like somebody who's drank a little bit of traditional liquor. They may be silly, they may be confused, they may have a staggering gait, all that good stuff. And if they've had lots and lots of ethylene glycol or methanol, they're going to act just like somebody who is overdosed on traditional alcohol that you would find like in a bar. So they may be comatose, they may be having seizures, things like that. Now, when we talk about the classic presentation for ethylene glycol or methanol overdoses, usually when these patients present to the ED, they have a significant change in their level of consciousness, and thus that's why somebody called 911 or somebody took them to the hospital. A lot of times they'll be unconscious, comatose, or seizing. When we start working these patients up, anybody in a coma we typically do a blood gas on, and the big thing that tips us off it's ethylene glycol or methanol poisoning is the patient has a profound metabolic acidosis that we can't explain from another reason. So we start going down our checklist of metabolic acidosis. Is it a lactic acidosis? No, it's not. Is it renal failure? No, it's not. Is it DKA? No, it's not. Okay, well, it may be ethylene glycol or methanol poisoning. Now, the other thing that we see that goes hand in hand with the profound metabolic acidosis is the patient will also have an osmolar gap. Well, what in the world is an osmolar gap? Well, if you remember, when we measure somebody's serum os, what we're measuring is basically how thick their plasma is. And the more stuff is in plasma, the more molecules of stuff, the thicker the plasma is going to be. The more fluid there is and the less stuff there is, the more thin their plasma is going to be. Well, there's two ways for us to measure the serum os. One of the ways that we can measure it is we can actually calculate it. And a lot of times in your laboratories, when you get back like a chemistry 12, that's one of the things that's already calculated on there. It'll have a calculated osmolality, which is based on the patient's sodium, their BUN, and their glucose. Well, the second way that we can measure the osmolality is we can directly measure how thick the serum is. And in a normal, healthy person, the calculated serum os and the measured serum os are very close together, usually like within 10 of each other. And so we say a normal os is usually like somewhere around 275 to 295. So whatever the calculated os is, the measured os should be within about 10 of that. Well, when somebody has ethylene glycol or methanol poisoning, they have a really high osmolar gap. And what that means is that their calculated osmolality is nowhere near what their measured os is. So when we calculate their os, we may say come up with 292, but when we directly measure their os is like 320. So there's this huge space between the calculated os and the measured os. And again, that's classic for ethylene glycol and methanol poisoning. Other physical assessment types of things that we'll see, the patients will have nystagmus. When we talk about deep tendon reflexes, typically they'll be depressed. We already talked about the fact that the level of consciousness will be depressed. And a lot of times what we'll see in these patients as well is they'll have a change in their temperature regulation. They may be hypothermic or they may be slightly hyperthermic. A lot of times these patients have profound hypocalcemia because they have QT prolongation. And the big thing that's going to happen to these patients is they're going to have liver failure, and they're also going to get renal failure if they're not corrected, if they've got a profound ethylene glycol or methanol poisoning. Now, when we talk about the treatment for these patients, remember that just like anybody else who's consumed a large amount of alcohol, one of the first things we want to do is make sure they're not hypoglycemic. And we just kind of follow our standard coma protocol. When we check the blood glucose, if the blood glucose is less than about 70 or 80, depending what your protocol is, then we would give the patient sugar. When we talk about the actual antidote itself for the ethylene glycol or the methanol, we basically have two choices. The first choice is we can actually give them a true, honest-to-God antidote, and that drug is called fomepizole. The big problem with fomepizole is it's really, really expensive, so a lot of places don't carry it. Instead, what a lot of places do, what a lot of facilities do, is use ethanol to compete with the ethylene glycol or the methanol. So basically the way we treat these patients is we get them drunk. We give them an ethanol infusion, and remember the way that works is ethanol competes with the same receptors that ethylene glycol or methanol compete with. So when we're giving somebody ethanol, we're giving them a less toxic alcohol that's going to compete and bind to those receptors more readily than the toxic alcohol being the ethylene glycol or the methanol. The other things we want to do for those patients, we want to make sure that their vitamins are adequate. So we typically give them folic acid, we typically give them thiamine, and the other thing that we'll typically do is give them pyridoxine. Okay, when we talk about hydrocarbons, remember hydrocarbons are anything that's hydrogen-based that also has a carbon base to it as well. So good examples of that would be things like turpentine, gasoline, things like that. The big thing to remember with hydrocarbons, that if you were to remember one thing about them, the one thing to remember is that they tend to cause pneumonitis and respiratory problems. Remember that when patients overdose on hydrocarbons, typically most hydrocarbons are less viscous than water. They're very slippery. And so your body has been accustomed all these years to opening and closing your glottis as you swallow water or substances, liquid substances that are about the same density as water. Hydrocarbons are so slippery that a lot of times, even when you bronchospasm and even when you close your throat to swallow liquid, the hydrocarbons can still seep past that and actually end up in the lungs. The other big problem with hydrocarbons is hydrocarbons also tend to put off lots of fumes, and so if you're swallowing hydrocarbons, even if the fluid itself isn't getting down into your lung space, the fumes cause the same kind of damage. So the big thing we said was pneumonitis, and that pneumonitis can be anything from a small amount of pneumonia type symptoms all the way up through ARDS and respiratory distress. A lot of times the other things we'll see in these patients is tachyarrhythmias. Remember that hydrocarbons are both toxic not only to the lungs but also to the liver and to the kidneys. And finally, the big thing to remember about hydrocarbons is we never ever want to make these patients throw up. We don't want to do anything to make these patients throw up, because every time they throw up, because of the viscosity, we have the potential to put more hydrocarbon in the lungs and make the pneumonitis worse. When we talk about the treatment, if the patient has been covered in it, obviously the big thing we want to do first off is we want to decontaminate the patient. If the patient, once the patient's been decontaminated, then our priority is obviously managing the lung issues, and we do that with oxygen. If the oxygen is not cutting the mustard, then obviously we can go to intubation. Remember, again, you do not want to induce vomiting in patients who have ingested hydrocarbons. Now, some other things to think about: if the patient goes into cardiac arrest, one of the things that hydrocarbons do is they cause a phenomenon called myocardial sensitization, and that's where the heart is really sensitive to alpha and beta stimulation. So your catecholamines that we typically give in an arrest, like your epi and things like that, we don't want to use those in a hydrocarbon overdose. So again, I'll say that again. We don't want to use epinephrine in a cardiac arrest from hydrocarbons. Now, as far as lavaging these patients and things like that, the advice that I have would be to contact poison control and get a little bit more discretion or a little bit more feedback about whether lavage is going to be a safe thing for these patients or not. There's a lot of people who err on the side of conservative because of the potential for the patient to vomit when you put a lavage tube down. Then there are others that say no, you can do this safely and you can lavage. That's a decision I would make with my local poison control center. Okay, now when we talk about street drugs, some of the common street drugs that we deal with, let's start with cocaine. Remember, the big thing with cocaine is the patient has an increase in sympathetic tone. With that increase in sympathetic tone, the patient's going to become hypertensive, they're going to become hyperthermic, and they're going to become tachycardic. When a patient has a severe cocaine toxicity, that hypertension can lead to a malignant hypertension that causes a headache. The patient also can even have an increase in hypertension to the point where they have an increase in their ICP and either become stuporous or start to have seizures. A lot of times patients that overdose on cocaine will become nauseated and vomit, and the other thing is because their heart is beating so fast to try and keep up with their hypermetabolism, these patients will often get ischemia. So a lot of times these patients also have chest pain and shortness of breath, very similar to what we would see when somebody was having myocardial ischemia for any other reason like an MI. When we talk about the treatment for these patients, the biggest thing that we need to do for these patients is cool them down. Remember that the hotter you are, the longer you are, the more chance you have for muscle breakdown, and when we get muscle breakdown, we get rhabdo. So we want to watch out for rhabdomyolysis in these patients and try to prevent it by getting them cool. When we talk about the main treatment pharmacologically, the first line drug for cocaine toxicity is benzos. We like to use our benzos. They work well. A lot of times these patients, the only thing that you'll need to give them to manage them is something like Ativan or Versed or something like that. If the benzos don't work, it's specifically if the patient starts to seize. The other thing we could do is we could give these patients barbiturate, like pentobarb or something like that. And remember that the general rule in cocaine toxicity, as the literature stands now, is that if the patient is in a hypertensive crisis, the one drug we do not want to give them is a beta blocker. Remember back from your anatomy and physiology that beta 2 receptors cause vasodilation, alpha 1 receptors cause vasoconstriction. So if I give you a non-specific beta blocker, that beta blocker is going to block beta 2. If it blocks beta 2, that makes alpha 1 dominant, and so the patient is going to go into a hypertensive crisis that we can't get them out of. So we typically do not use beta blockers with cocaine overdoses. If the patient is hypertensive and it's a hypertensive crisis that needs to be treated instead, the drug of choice is actually an alpha blocker. In addition to that, the other drug that a lot of places do use, in addition to alpha blockers, instead of using an alpha blocker, is they'll use nitroglycerin. And most of the time, these patients, like we said, will have chest pain and shortness of breath. So we'll start nitroglycerin anyway, just like if they were having an MI. A lot of times, that in and of itself, with good titration, can drop their blood pressure to an acceptable level. Okay, when we talk about methamphetamines, the big thing about methamphetamines is that they cause a lot of the same symptoms that cocaine does, plus they cause all kinds of additional problems. When somebody overdoses on methamphetamine, they've also got an increase in sympathetic tone, just like the patient who's cocaine toxic. We can see that they get chest pain and tachycardia. We tend to see that people that are on methamphetamine tend to be very, very agitated. If they're not very agitated, the other thing that they are very commonly is paranoid. So when we talk about managing the methamphetamine overdose patient or the methamphetamine toxic patient, the biggest thing to remember is your safety comes first. It's not uncommon for these patients to be very paranoid, and anything that you do that they perceive as being limiting to them, they're going to react out of what they consider to be a self-defense mechanism. Going hand in hand with that, it's so common for these people to be paranoid that one of the things you want to do is you want to assess these patients very quickly to make sure they don't have any weapons on their person. It's very common, extremely common, for people who are using meth to be carrying weapons. As a police officer, we teach other law enforcement officers that if you find meth, you're going to find a weapon. It's kind of one of those things you expect to find. When we talk about the terminal effects, if the patient has such a profound hypertension or has such profound toxicity, we may actually see that there's alterations of the level of consciousness, which may be anything from psychosis to seizures to being comatose. When we talk about the treatment for these patients, the big first thing we do for them is just like any other patient, we manage their ABCs. When we talk about sedation, droperidol and Haldol tend to work very well for these patients. These kind of tend to be some of the more common drugs we use, droperidol and Haldol. If the patient is actively seizing, we can treat that with benzos. And if the patient is hypertensive, we'll treat their hypertension with vasoactive drugs, things like nipride or phenoldiazepam, things like that. The big thing to remember with these patients is, as a general rule, like the patient who overdosed on cocaine, we typically want to be very cautious about using beta blockers. If the patient is tachycardic but not hypertensive, beta blockers may be appropriate, but if the patient is tachycardic and hypertensive, then we would probably be wise to hold off on the beta blockers or at least get some additional consultation from a cardiologist. Okay, when we talk about street drugs, some other drugs that we may come in contact with are hallucinogens. Remember that all of your hallucinogens, by definition, are neurologic drugs. Thus, the reason why patients get hallucinations. And remember that your hallucinogens basically fall into one of two categories. They're either a stimulant or a depressant. Most of your hallucinogens are stimulants. Most of them are going to cause stimulant-type reactions. In other words, the patient's going to be tachycardic, patient's going to be hypertensive, patient's going to be tachypnic. But there are a subset of hallucinogens that actually have cholinergic effects to them as well. And so in those patients, what we would see is that they're often going to be bradycardic, they're often going to be hypotensive, and they're going to have a lot of the sludge-type responses like we see with organophosphate poisoning. When we talk about the treatment for these patients, the big thing again is like anybody else, we want to manage the ABCs. Try and put them into a quiet, dark place if you can. The less stimulation they have, the better. The more stimulation they have, the more they're likely to have hallucinations and acute confusion and psychosis. So we would like to try and put them in a quiet place. When we talk about drugs to sedate them, we can use like drugs. We can use drugs like benzo or Haldol. If the patient's hypertensive, we treat that again with vasodilators like nitro or nipride. Again, we want to avoid beta blockers, and if the patient is really, really hot, if they're a stimulant hallucinogen overdose, then again, just like with cocaine and just like with meth, we want to watch for rhabdo. Okay, when we talk about benzos, remember that the big thing that benzos are going to do when somebody overdoses is they're going to decrease the level of consciousness, they're going to decrease the respiratory rate, they can cause hypotension. When we talk about the treatment for these drugs, the treatment of choice is flumazenil or romazicon. And the big thing to remember about romazicon is it's a great drug for what it was intended for. Romazicon was developed as a drug to use in patients who were inadvertently or purposely overdose with benzos in a medical environment, i.e. like you have a patient who comes in who's got a dislocated shoulder. So we give him Versed, we give him fentanyl, we pop his shoulder back in place, and then we give him romazicon and Narcan to reverse those two drugs. It is not a good drug for patients who are chronically addicted to benzodiazepines. So like if you have somebody who's sitting at home and downs a bottle of Xanax, those patients are not well treated with romazicon. And remember that the big thing that can happen is that in theory you can put them into instant withdrawal, and that instant withdrawal tends to cause seizures, and if the patient starts to seize, then what are you going to do? Give benzos? So you kind of end up in a chicken and the egg kind of scenario. So we would prefer not to use romazicon in people who are chronically addicted to benzos. For those patients, we basically just manage them symptomatically. We maintain their airway, make sure that they've got an adequate tidal volume and minute volume, make sure that they're adequately oxygenating, and if they're vasoconstricted, we can treat that vasoconstriction with if they're vasodilated, we can treat that vasodilation with vasoconstricting drugs like dopamine. Now, when we talk about narcotics, funny enough, narcotics have the same issues that benzos do as far as the potential for these patients who are chronically on narcotics to go in instant withdrawal when we give them Narcan. We all know Narcan is the antidote for a narcotic overdose, but there's a growing consensus that a lot of times if these patients are chronically on narcotics, i.e. like your heroin users, your patients that are addicted to oxycodone, things like that, that we should probably manage these patients more like the way we manage chronic benzo overdose patients. And that is symptomatic. We should maybe protect their airway, make sure that they've got good oxygenation and ventilation, and manage their hypotension if they have it with pressors. But if we know that it's a narcotic overdose that's a new onset narcotic overdose, we know the treatment for those patients is Narcan, and I'm sure most people have given Narcan before, but if you have not, one of the things you should know is that it's going to work almost instantaneously. And when I say almost instantaneously, I mean like typically within 30 seconds. Remember that if the patient has overdosed on synthetic narcotics, you may have to give very high doses. So while we would typically give a dose of like 0.4 milligrams to 2 milligrams of Narcan, if it's a synthetic overdose, a synthetic narcotic overdose, it's not uncommon to have to give these patients like 10 or 20 milligrams of Narcan. Know again that if your patient is a chronic narcotic abuser, that almost instantaneously they're going to show withdrawal symptoms, which can be being combative, they can't seize, they can't vomit, and that's really troublesome if the patient's not had a complete and total increase in their level of consciousness. So we want to be very cognizant of managing all those issues before we actually push the Narcan, if we're going to push it at all. Okay, you've got your antidotes there for selected poisonings. When we talk about carbon monoxide, remember that the big treatment for carbon monoxide is we want to compete by hyperoxygenating the patient. There's kind of two theories on how to do this. The first theory is to put patients on 100% oxygen and allow them to spontaneously recover. With most carbon monoxide poisonings, that can be accomplished in somewhere between anywhere from 2 to 6 hours on 100% oxygen. The patient will recover. The second theory is that we can actually take that patient and put them in a hyperbaric chamber. The big thing that we have problems with a lot of times is the logistics of getting them to a hyperbaric chamber. So a lot of people have looked for consensus in the literature about who does and doesn't need to go to a hyperbaric chamber. And if you kind of evaluate all the literature that's out there right now, basically what you find is it comes down to, can the patient wait 4 to 6 hours or not? If we've got, say, a 19-year-old female who has a carbon monoxide poisoning, but the patient, when they present to the ED, has no lactic acidosis, she's not tachycardic, she's not hypotensive, she's not got any EKG changes, she's just got neurologic changes, a lot of times she'll do just fine to just put her on an auto breather. In contrast, if you've got, say, a 60-year-old male who's got a history of coronary artery disease and the hypoxia that's associated with the carbon monoxide poisoning is causing the patient to have EKG changes, we're seeing the cardiac enzymes go up, we may see the presence of lactic acidosis, that guy cannot wait 4 to 6 hours, so he needs to go to hyperbarics as soon as possible. Same thing if we've got, say, a younger patient who's pregnant, the baby is decelling, or the baby's got a sustained bradycardia, then again, that mom can't wait, that baby can't wait, so they need to go to hyperbarics. Okay, when we talk about cyanide toxicity, remember that the big drugs we give those patients are amyl nitrate, sodium nitrate, and sodium thiosulfate. Those are the 3 drugs of choice for treatment of cyanide toxicity. When we talk about organophosphate toxicity, remember our 2 drugs of choice are atropine and 2-PAM. When we talk about methemoglobinemia, the big drug of choice to manage those patients is methylene blue. We know that anticholinergic overdoses are treated with physostigmine or physostigmine, depending on what part of the country you're in. Coumadin is treated with vitamin K and FFP. Heparin we treat with protamine. And finally, we've already talked about beta and calcium channel blockers. Beta blockers we treat with glucagon, and calcium channel blockers we treat with calcium. Last but not least, when we talk about snake bites, remember that snakes in the U.S. are broken basically into 2 categories. We have pit vipers and non-pit vipers. And when we talk about pit vipers, we are talking about water moccasins, we are talking about copperheads, and we are talking about rattlesnakes. Those are our 3 most common snake bites in the U.S. When we're talking about non-pit vipers, we really only have one that's native to the U.S., and that is the coral snake. So when we talk about coral snakes, the other snakes that would be in that class that we typically would not see in the U.S. unless they were brought here would be snakes like cobras, asps, things like that. Now, when we talk about let's talk first about the non-pit vipers, the coral snakes and cobra snakes and things like that. The big thing to remember about those snakes is they're neurotoxic. You guys all give paralytics, and you know what paralytics do. When you give somebody a paralytic, if you give them a little bit of a paralytic, it causes weakness. If you give enough of a paralytic, like the therapeutic dose that we typically are giving them out when we're giving paralytics, then you're going to have complete paralysis. Well, with a coral snake or other non-pit viper type bite, that's the effect you're going to see. If there's a little bit of toxicity, you may see muscular weakness and neuromuscular symptomology. If there's a profound toxicity, you may see everything up to the point of complete paralysis and respiratory failure. So we're going to treat those patients symptomatically. That's basically what we do for them. If the patient's intubated, if the patient's respiratory failure, intubate them. If the patient's not got the strength to be able to maintain an adequate minute volume, intubate them. Treat their hemodynamics symptomatically, i.e. if they're vasodilated, give them pressors. If they're hypertensive, give them vasodilators. We basically just treat them symptomatically. There are antidotes out there for various non-pit viper snake bites, but by and far in most institutions, unless they're specifically a toxicology institution, they're probably not going to have those antidotes. So it's not something that we stock in the average ED. Okay, now let's talk about the pit vipers. When we talked about pit vipers, we said that was like our rattlesnakes, our water moccasins, and our rattlesnakes, our water moccasins, and our copperheads. The big thing to remember with these bites is they're hemotoxic. We've spent lots of time in various other portions of this course talking about DIC, and that's essentially what happens with these guys when they're bit by a pit viper. We see a DIC type phenomenon. The hemotoxins cause all kinds of coagulopathies. In addition to that, these bites are also tissue toxic. They're damaging to the tissue around the bite site. So we can see necrosis around the bite site. And the other thing that we see is lots and lots of swelling. In fact, the more profound the bite is, the more swelling we have. So in addition to managing the coagulopathy component, you may also have to manage an isolated compartment syndrome in the extremity where the bite occurred. Now, when we talk about the incidence of pit viper bites, by and far, most bites in the U.S. that occur from poisonous snakes are pit viper bites. It's much, much more common than coral snakes. Remember that about 20 to 25% of your pit viper bites are dry bites, meaning that when the patient was bit by the snake, that while the snake bit them, they injected no venom. So the patient, the big thing that will tip us off that this has occurred fairly quickly is we will not start to see the extremity swell like we will if the patient's actually got a toxic bite. When we're talking about treatment for these patients, the big thing you want to do is, probably the most important thing you want to do is you want to trend the swelling, and you want to watch how quickly the patient's swelling. And the way we do this is we find the edge of the swelling and we mark it, we write the time, and we continue to do that up their extremity. The faster the patient swells and the less time, the more toxic the bite is. So that information, the identifying the points of swelling in time, is very, very important information for the toxicologist that's going to manage that patient. They're going to make a lot of their decisions based off of how quickly the extremity swells. Now, just to make life really, really great, there are a couple of subsets of rattlesnakes that actually have the same effects as all the other pit vipers, plus they also have some neurologic effects, just like the coral snakes and cobra snakes do. So when we talk about these types of rattlesnakes, the classic ones that we talk about are like the Mojave rattlesnake. The Mojave rattlesnake is not only hemotoxic, it's not only going to be necrotic to tissue, but in addition to that, it will also be neurotoxic. So again, we can have weakness all the way up to and including respiratory failure. Other things that we may see in these patients, a lot of times they'll be sweating, a lot of times they'll be cold, so they'll have that kind of cold sweat kind of thing going on like you see in patients with shock. It's not uncommon for them to be hypotensive because of a distributive shock. They may have muscle fasciculations, and those muscle fasciculations can be so profound that they can cause rhabdomyolysis. We can have local bruising, and obviously the patient is going to be weak. When we talk about the treatment for these patients, the big thing we want to do, obviously, is we want to clean and immobilize the bite. Remember that we don't cut and suck anymore. We don't put tourniquets on anymore. We don't put ice on the bite. We don't do any of that stuff. Just clean it and then immobilize the extremity. And remember that the extremity is probably going to get a compartment-type syndrome if we don't get an antidote on board fairly quickly. So when you're splitting, you want to split appropriately for that swelling that's going to occur. We want to monitor for systemic reactions, and remember that there's a subset of the population who will get anaphylaxis with their very first snake bite. Even though they've never been bit by a snake before, they'll still develop anaphylaxis. Now, when we talk about the antivenoms, there's two antivenoms that are out there, Crofab and polyvalent. Polyvalent was the first one, and it's the one that existed as the only available antidote for a long time. The big thing with polyvalent is polyvalent tends to make patients critically ill. It's not uncommon that when you put somebody on polyvalent, you end up managing their polyvalent toxicity as much as you're managing their snake bite toxicity. A lot of times these patients end up intubated with ARDS on multiple pressors. They end up very, very ill. But if that's the only antivenom you have, that's your only choice. What you would prefer to have if you have it available is Crofab. Crofab is the newer version. The newer antivenom for pit viper overdoses works much better. The big thing with Crofab is we don't have a lot of the systemic effects like we do with polyvalent, so a lot of times these patients tolerate, patients that would never tolerate polyvalent will tolerate Crofab quite well. And finally, remember the last thing we want to do is we want to be watching that compartment serially. And if we're starting to see signs of a compartment syndrome like our 5 Ps, our paresthesia, pain, pallor, pulselessness, all that good stuff, then we may want to consult somebody about doing a fasciotomy or follow our protocols about doing that. All right, that is all we have for toxicology. Thank you very much for spending this time with me. I hope that you have a great day.
I'd come for you, no one but